Dr. Bhargav Raman. He's going to talk about 10-10-10 certification program that he's the founder, and he's a Stanford-trained physician executive with 25 years of experience spanning clinical medicine, AI, ML, healthcare economics, and product strategy. He has held leadership roles uh, at VIVIO Health, Carrum Health, and Oration Health, and now co-leads 10-10-10's mission to dramatically improve healthcare value. All right, Bhargav, welcome to InnovatorMD, and the stage is yours.
Thank you. You guys can see the presentation?
It's coming through well.
Okay. So you guys have all seen this slide. The US healthcare system is broken, almost every single slide. But we're going to change the conversation just a tiny bit. Let me ask you a question. If you're an investor, would you rather take 5% of a $280 billion pie, or do you rather take 10% or $10 billion of a $100 billion pie? And if you're, and we don't have a lot of time for question and answer, but if you picked option one, you would be right. And if you really think about it, from our perspective, from 10-10-10's perspective, this is why healthcare is broken. It's, you can blame patients and doctors and all you want, but in the end, most of the money is going elsewhere. It's not going patient care. So when I talk about being an extractive system, I've only put 4 examples here out of many, many examples of extraction system. One of them being shared savings. A lot of people love shared savings as an incentive, aligned incentives, for example, right, between the company and the thing. But shared savings has become, an extractive play now, to the extent that you take as much as the savings as possible and leave the practice with nothing in the end. Pharmacy rebates, been fighting it since 2010, 2007 in various startups, but it's now becoming more and more prevalent in the literature about how extractive this is. People who have been trying to sell to employers know about broker kickbacks and consultant fees. You can't get in the room unless you pay the fee. And at VIVIO Health, which Uli mentioned a little bit ago, we refused to do this, which reduced our catchment area significantly. But that's because we had the ethical gumption to not pay these fees. So when you look at everything, now this makes sense. The reason we have really bad health outcomes while we spend so much is because the money is not getting to where it needs to be. It's being extracted. So I've spent the past 15 years trying to fix this in various companies, and they haven't changed healthcare. And there's a few reasons for this. And we talked a little bit about it right just now. Number one, distribution is captured by intermediaries. That gate your access to the ultimate customer. Benchmarks are set by the incumbents. And when I mean also the benchmarks, also the business models are set by the incumbents. So after the first incumbent has an extractive business model, every company after that has the same business model because they see the profits. And then finally, there's no independent signal of truth. And I'm going to be talking more about number 3 today, and then talk about how we're going to deal with number 1 and 2 a bit later. But there are a lot of certification programs, things like that, Validation Institute, one of them, right? PHDI, but none of them look at the whole system, number 1. And number 2, many of them are pay to play. So you pay them, they give you a certification. They figure out a way, right? And so our North Star is that the United States should be a top 10 for health outcomes, spend no more than 10%. Of their GDP and achieve that within 10 years. So how are we going to do that? So we started with this certification program, and it's a standard in the field for solutions that actually work. So there's individual, so we look at health outcomes and we look at equity. So I'll talk about that in a second, just a second. No. Okay. Sorry, my son is on summer school. All right. So I'm going to start with what companies actually get by getting certification with us. So you get access to our expert panel. It's growing every single day. It's massive as it is. Get featured in our playbooks, which I'll talk a little bit more about later. But these playbooks will go to potential customers, and you also get independent market recognition. The certification has three pillars: outcomes, economic benefit, and equity. Many people forget about equity, but it's very important. If you don't take care of the people who most need it, it just goes to the people who least need it, which explains a lot of solutions out there and why they're not changing healthcare. The same with economic benefit. If the solution, part of the ROI that they put out is the amount of money that they've extracted from Medicare or Medicare Advantage or anything else, that's not ROI. That's cost, because that's cost to the patient, cost to the system, that's premiums increasing. So we look at this from a system perspective. Right. So from our perspective, there's only one combination that actually bends the curve for the system, and that's when all three pillars are met. So we have several certification levels here. I won't go into them in detail. The ones that we're really looking for are the catalysts, the one that meet all three pillars, improve all three pillars. Those are the ones that we really, really want. There's provisional and full. Provisional is mainly meant for startups, people who have pilot programs, people who can potentially have transparent modeling that predicts outcomes or economic benefits. And the idea behind that is that we get the startups in to our system, startups or early solutions or even policies into our system a little earlier in the process, so that we can guide how they create their business models, how they collect data. So for certification, it's a 2-week path, and assuming all the data is present. If the data is not present, then we help to figure out how to analyze the data that they do have, or to collect the data that's needed for certification. So this is very much being a thought partner with the solution. Now, I wanted to add a few slides at the end, just really talking about how we are implementing this, because there's no point having a certification without an activation engine, without a way of these solutions actually getting into the market. So we're starting with value-based care. Why? Because primary care is the foundation of our healthcare system. If we are able to fix primary care, as Jake was talking about just a little bit ago, we're able to fix that, then we will be able to fix the healthcare system, because that's where the decisions are made. That's the front door. So what's the extraction in primary care, especially in value-based care, right? These are MSOs, physician enablement companies, insurance companies. They want the practice to take risk early. They want the practice to start paying admin fees day one, and they want their shared savings, right? You reduce inpatient costs by 10%, they want 5% of that, leaving very little for the primary care practice in terms of margin to actually improve care for the patients. And then finally, and this is very, very important, Agilon is a very good example of this, which has been in the news recently, is locking in the primary care practices for decades sometimes, including the vendor contracts. So the primary care practices don't have direct vendor contracts. They go through this other company. And so if they want to end the contract, they can't. They have significant lock-in. So with us, what we're building is basically it's a membership with 10-10-10. So we want to build a large community of primary care practices that are helping each other. And that's going to be built around these open source playbooks, which are going to start being published next week. So watch this space and follow us. And these playbooks are operational playbooks for value-based care, completely open source, and built by a large task force that we've assembled of various VPC leaders, including Jen Block, who has joined us today. And then there's no point doing any of that if we don't have activation next to it. So we have consulting as well. There's cost plus consulting. This is how we fund all of this. And essentially what this does is contextualize these playbooks to each practice so that they can succeed in VBC without the need of any other intermediaries. again, how we are different. We do not, I mean, the main thing is that we're a nonprofit. So we will never take a cut of the shared savings. If the primary care practice does well for their patients, they should benefit. The money in the end should go back to the taxpayer, not to some middleman. So for value-based care, this is just a big slide, but I'll be very, simple about it. In the end, we do not believe there need to be any intermediaries between the patient and the primary care practice and the ultimate payer, which is, the patient, other than perhaps an intermediate aggregator like Medicare or the employer, right? Or Medicaid, right? Other than that, there should not be any intermediaries between the primary care practice and the patient. So we want to get rid of any extraction that occurs in this space. So how you can help? You can go to our site, sign the pledge. You can donate. We do have so all the free assessments that we're doing for primary care practices are fully funded by grants and donations. There is significant volunteer opportunities, looking for data analysts and engineers as well. We have a 5% engineering data analytics team that's completely volunteer right now. We're looking for more. PR, social media, still looking for volunteers there. Join us in some way if you wish to undergo certification or you wish to partner with us. Just reach out and connect with us, because there's way more coming down the pipeline over the next few months.
All right. Thank you very much, Bhargav. Are there any questions for Bhargav? I want to see some hands if you have questions. Bhargav, how did you come up with this idea, and how did you get the seed funding or pre-seed funding to be able to do this work? I mean, this looks like a very powerful way of managing and monitoring and a huge piece of the health systems. How did you come up with the funding?
Yeah, I think it's so there's one major thing, which is I think going to change healthcare, and that's AI, right? And because of the use of AI, I think a lot of cost goes out the window when trying to open source things. So I think I mean, this is me kind of on my soapbox a little bit, but AI is a massive democratizing force. More than that, it's actually made for open source. It's not made to build billion-dollar companies that are vendors to other billion-dollar companies. It's really each company can build their own AI now and their own systems. And it's the same with us. So when we're creating our, we have open source code and stuff like that that's going to be coming out over the next few months. And I mean, AI basically reduces the cost of all of this, number one. Number two, we have a small community of folks who are very interested in what we're doing. And so we're running on small donations right now. I've applied for large grants, but those small donations are helping us continue this work. All of us are currently volunteer doing this through nonprofit, and so this value-based care initiative will bring us more funding down the line, and so at some point we will have repeatable funding to do all of this, and that's part of the reason the consulting is cost plus. So that's the cost, and then the plus is going to go and fund all of our other initiatives, including healthcare price transparency, and things like that down the line.
Great. All right. Thank you very much. Let's see if there are any questions for Bhargav. Let's see. I want to see who else joined while we are talking here. Where are my participants? Okay.
Can I add what I just said, Uli?
Yeah.
So
Go
I'm
ahead.
just going to repeat what I just said. I am addicted to value-based care, having worked for Kaiser Permanente for 18 years. I'm retired now, and I just wrote all this, that We have among the best clinical outcomes on the planet, obviously not in every way, but in most ways, like Mayo and like Hopkins, everyone else. And we do, I'm exaggerating to make a point, half the number of procedures of those other winners like Hopkins and Mayo. The doctors are salaried and they get incentives based on clinical outcomes and patient satisfaction. I am so loyal, I'm so addicted. I would not live anywhere where I could not get KP/value-based healthcare, and I wish the whole country would go there. Thank you for listening.
All right.